everyone. I'm Solène Claverel. I'm Head of Medical Education and Scientific Engagement at Myeloma Patients Europe. And today I will be moderating our webinar on living well with AL amyloidosis. Today, I'm very, very pleased to welcome our two speakers coming from the Netherlands. So I will start with Professor Monique Minnema. She was trained as an internist and hematologist at the Academic Medical Centre Amsterdam and the University Medical Centre Utrecht in the Netherlands. She started working as a hematologist in 2005 at the Department of Haematology, UMC Utrecht, and she was appointed full professor in 2019. She's a multiple myeloma and AL amyloidosis specialist, and she's also author on several national and international guidelines on the diagnosis and the treatment of plasma cell diseases. She's founder and also medical lead of the hematology clinical research team of the EMC Utrecht, and she participated in many breakthrough clinical trials, and her main focus of clinical research is the development of novel therapies and new research structures for hematology research in the Netherlands. Our second speaker, Ms. Karin Aarsman, is a nurse practitioner in hematology. She's part of the same team, so the multidisciplinary amyloidosis team at the EMC Utrecht Center of Expertise in the Netherlands. She thinks that enhancing awareness to promote earlier recognition of AL amyloidosis and timely referral is a shared mission between different healthcare professionals, and in her role she's committed to delivering personalized care, and she will talk more about this during her presentation, and ensuring close collaboration between the various disciplines involved. So she has many years of experience in oncology, nursing, hematology, and stem cell transplants. So we are very grateful you two can join us today. So thank you, Professor Minnema and Ms. Aarsman, for being there and for dedicating some of your time to MPE. So Professor Minnema, the floor is yours for your presentation.
Well, thank you so much, and thank you all for attending. I will start sharing my slides, our slides. And then I will start with my presentation. So I was asked by Myeloma Patients Europe to tell something about especially the symptoms that patients experience with AL amyloidosis, but also because of the treatment that they receive, and with that also perhaps some options for management of those complaints and symptoms. And for that I would like to share first that AL amyloidosis is, of course, a systemic disease. So patients can experience many symptoms on many different organ systems. And what's also striking in AL amyloidosis is that those organs involved are not the same in every patient. So the combinations of these 7 depicted organs here can differ, but most of the patients have 2, 3, or 4 organs involved when the disease is diagnosed. And when you look at all the organs, we have the heart and kidney. This is the liver that can be involved, the stomach and the bowel system, your nervous system that has many components. It's motoric, but that's hardly ever involved in AL amyloidosis, but mostly sensory, so how you feel and how you can sense the environment, but also sense pain. And the autonomic nervous system, which is a bit more complicated, but when I explain it to patients, we mean with that the things that go automatic in your body. That you, for example, that you swallow your food, or that your bowels move and produce your feces just when you need to. That's something that you don't do as well as when you're born, but that's something that develops later on in life, and it's just automatic. We don't think about it anymore. Soft tissue. This is a tongue that is depicted, so you can have an enlarged tongue, but also other sites are involved. And for example, in the diagnostic pathway, a fat pad aspirate is done in many patients, and that's also soft tissue taken from some fat tissue, mostly from the belly. But also lungs can be involved, and mostly it's the pleura, so the outside of the lungs that can be involved in AL amyloidosis. And if you look at the frequency of all those involved organs, for the lungs we don't know that well because it's very difficult to diagnose, but you can see here that heart and kidney involvement is seen in many patients. Around 60% of patients have an involved kidney, mostly a nephrotic syndrome, and 70% heart involvement, but also your nervous system and soft tissue involvement is seen many times in patients. And if you then look at the specific complaints that patients have with this type of involvement, I mentioned some of the main symptoms. So I don't want to be mentioning all the symptoms, but just some of the main symptoms patients can experience. And for the heart, it's mostly fatigue, especially when you're walking or walking up the stairs or trying to have some more intense exercise. Then patients have a fatigue, so you have breathlessness, short of breath, and you feel really fatigued, and you stop your exercise or the movement that you're doing. But also edema, so fluid in your belly or your legs can be seen with heart involvement. That's also seen with kidney involvement. So kidneys, normally they still work fine, but they lose a lot of albumin in your urine, and that also leads to edema, to fluid retention. So you can see it also in your legs or in your belly. Liver involvement rarely has any complaints at all. Stomach and bowel involvement has complaints like weight loss, but also bleeding from your bowels can happen. And the nervous system involvement, patients have problems with their blood pressure, so dizziness, but also pain, especially in the lower legs, and also problems with food intake because swallowing is becoming much more difficult. It can happen with autonomic nervous system involvement. Well, soft tissue, you can imagine if you have a very big tongue, macroglossia is how we call it in the medical terms, then also food intake can be very cumbersome, and also joint pain can happen when you have soft tissue involvement in your joints. And lungs, it's rarely involved. It's more pleural fluid that can be seen, and liver and lungs will not be discussed in this webinar today. So I will discuss heart, kidney, the edema, dizziness, pain, and joint pain, and what we can do with those complaints, and also try to explain why this is happening. So edema can cause by heart involvement and kidney involvement. So why do we have this? If you look at the heart, it's because the heart it's still pumping enough blood out, but it's not relaxing enough. So it's stiff and it doesn't relax very good, and therefore not enough blood can go into the heart, because in the end your heart is just a pump needed to pump your blood around. So this is pumping blood out in your arteries, and this is the system, the blue system, bringing all the blood back to your heart. So if your heart is too stiff, your blood will be I call it backlogged. It will be in this part of your body, and it will lead to high pressure in your venous system. And together with that, your heart walls are becoming thicker and thicker. So if you look at the holes where your heart is where your blood is going through, when your heart walls are becoming thicker, there's not enough room for all the blood to go through. And it's pressure on this backlogging, this pressure on this system, because your heart is too stiff, will lead to leakage of fluid outside the vessel system. So outside these vessels, and especially in the lower part of your body, you will leak some fluid from your vessel system, and that will cause edema. But also, if your kidney is losing albumin, and that you can see with the urine test, you can test for albumin or protein in your urine, that also causes that you leak much more fluid into your systems because there's a lower, we call it osmotic pressure. And you can perhaps remember when your physician will test your legs, or will look at your legs will look like this, and they will put a finger into it, and then you will see a nice dent or not so nice dent in your legs, and that means that you have fluid in your legs. So it can be caused by the heart and also by kidney involvement. So on the left, it's still the reasons why you have edema when you have heart or kidney involvement in AL amyloidosis. And on the right side, I want to talk about some actions we can take to diminish these problems. One of the most simple things to try is less fluid in the body, because your heart really has difficulty in pumping it around, and we must try to have less fluid in the body. And we do that with fluid restriction. So mostly patients are put on a maximum of 1.5 liter per day fluid intake, and that's mostly tea or water. But don't drink too much, because all that fluid will just build up in your body and will cause more edema. And also salt is important in that way, because if you have a high salt content in your body, then that will also remain, then fluid will remain in your body, and it's much more difficult to lose all that fluid in your body. And one of the main medicine that we can give is diuretics. And I depicted one here. It's called bumetanide. We also have furosemide. They are the same type of tablets, and they are very forceful fluid enhancers for your kidney. So they give the signal to your kidney, please pee more, go to the toilet much more, because you have to lose much more fluid inside your body. So diuretics is very important together with the fluid restriction, and then the edema can be less. The other way is also to think about pressure back. So when there's so much pressure on your legs because of the things I just explained, we can try to have some pressure back. So one of them is to see if you can have stockings. So if you have tight stockings on your lower legs, that will help also with your blood pressure, but also to diminish the fluid inside your body. And of course, what also helps is that you have your feet or your lower legs up. So when you're sitting down, try to have your lower legs up, and don't stand too much on the same place. But if you stand still, also the fluid will build up inside in the lower part of your legs. For the albumin loss in your urine, nephrologists also like to try a medicine. It's called ACE inhibitors. And it's thought that in patients with nephrotic syndrome, they can help to retain some of the albumin inside the kidney. But I must say it's not really proven in patients with AL amyloidosis that it works. And also patients with AL amyloidosis have low blood blood pressure, and these so-called ACE inhibitors, they also lower your blood pressure. So many patients with AL amyloidosis can't tolerate these ACE inhibitors, but if you can also try these to help with your albumin retention by the kidneys. And perhaps you notice it's a bit darker here, but if you make some movement, yeah, there's the light again. And then something about the dizziness. So dizziness can be caused by heart involvement, but also by the nervous system involvement. And the reason for the heart is because I think perhaps also we have this fluid restriction and you're using diuretics, but also because the blood is backlogged. So there's just not enough blood inside your heart to be pumped out. And when you have a lower volume of blood being pumped out by your heart, also your blood pressure will drop. Because that's your blood pressure. It's just the amount of blood and the tension that you have on your vessels. And that's the other problem in patients with AL amyloidosis, is that this smooth muscle, so all your vessels will have some muscle inside them. They are just not responding very well, for example, to changes in your posture. So normally when you lie down or sitting and you're standing up, all those small vessels, especially in your arteries, will have a very slight tension, so that your brain will receive enough blood from your heart. So they will have a slight, so your blood pressure won't drop. But if you have autonomic nervous system involvement, the vessel musculature is just too slow with this adjustment. And therefore, patients can experience dizziness, especially when they're changing their posture from laying down to standing up. So not enough blood, too slow vessel musculature, and dizziness can be a problem, especially, and it can also happen when you're exercising. And I want to give a big caution with that, because this can also happen when you're walking the stairs. And if you're walking the stairs and you become you experience dizziness, you can fall down. And you should try to prevent that. So please be careful when walking up the stairs or with any exercise. If you feel dizziness, just stop and sit down. Don't try to force this, because falling down from the stairs is very risk taking, and you can also break bones, of course. Then, other measures that we can take is, again, increase the blood pressure, and that can also be done with stockings. So stockings help for edema, but also help with increasing a bit of the blood pressure in your system. And move slowly when standing up. Stop exercising when feeling dizzy. And we do have some tablets. It's called myelodrine tablets, and they are blood pressure increasing drugs. So normally we have a lot of drugs in the medical field that have a low blood pressure effect, and this is one that can have an enhancing blood pressure effect. But I must say, for example, in the Netherlands, this drug is not reimbursed, and I don't know how it is in many other European countries. And so you have to pay, I think, some 20, 30, 40 euros per month to have this tablet. So for many patients, this is not possible, but they can help. And what's also important is that you don't take hot showers, don't go to the sauna, because if your skin is evaporating a lot of fluid, then also you can have low blood pressure. So also please be careful with hot tubs, sauna, and hot showers. And then I would like to move to pain. Pain can be caused by involvement of your nervous system, especially your sensory nervous system. But sometimes we see patients with pain in their joints, so in your elbows or your knees. And the sensory nervous system is damaged by AL amyloidosis. So you have deposits of amyloid on those nerves. And it's a strange way. It always happens on your longest nerves the first time. So if this is your back, your longest nerves will be in your feet. So mostly it starts with your toes and then your feet, and then it will go upwards towards your knees, and also hands can then be involved. It's a loss of feeling, but sometimes patients experience a more intense feeling, a loss of temperature. You don't feel that it's cold or warm anymore. You have pain during walking, but also pain during the night. So during the day, it's okay, but during the night, you can't have any, for example, sheets on your feet. And also in the end, you can have balance issues. So if you close your eyes because you have to wash your hair, for example, then you feel that you're not stable enough. And that's because you have some loss of balance feeling in your feet. And we call this polyneuropathy, or it's sometimes written down as PMP in your medical files. And these are the different types of feelings patients can experience with polyneuropathy. And I actually taken this slide from a diabetes informed website, because also patients with diabetes can have this polyneuropathy. So you can have a pins or needles feeling, an extreme burning feeling that it's very warm, also a little bit of tingling, like it's kind of electric feeling, painful cold feeling while your feet is warm, but it feels like it's painful cold, and also electric shocks or cramps are reported by many patients. I must say the joint pain it's a little bit more difficult to understand. We do think that amyloid can be deposited in your joints as well. Patients describe it as rheumatoid-like pains, and it's in your joints and the surrounding tissue, and it's I think we caused by the fraction that perhaps the amyloid deposits give there, but there's not a lot of research done for this, so we don't know for sure. So the countermeasures: take care of your feet. Take care of your feet. So look at them if there are no wounds, small wounds, or in your feet, that your nails are good, because you can have problems there that you just don't feel, and they can infect, for example. I do know that a lot of also medical sites advertise or give an advice to take vitamins, because we think vitamins, B vitamins especially, can help with your nervous system. And I don't have any problems with taking B vitamins, but I would like to warn everybody for vitamin B6, pyridoxine, because if you take too much of that, it can cause polyneuropathy. So please don't exceed the upper limit of total amount that is. You can find it on every website. It's 10 milligrams per day. Don't exceed that, because that can increase your polyneuropathy. And the other thing is, if you don't have balance, if you're unstable, use a walking stick, or use we call it a rollator in the Netherlands. So please don't be shy to use some walking aids, because it's much more important that you walk and that you don't fall down than that you just sit in the chair because you don't have balance. And what's also important, mention this to your health professional, because pain, we have some, I will explain later on, but sometimes these polyneuropathy symptoms can also be caused by the drugs that we give to treat AL amyloidosis. So that's very important to us, because then we need to do something about those medicine that we are giving you. And we can also prescribe pain medication. So I think most people know a paracetamol, and you can have morphines, but we try to be very strict with that. But you have special painkillers for pain caused by polyneuropathy, and I list them here. And sometimes we have to try a bit which one works best for you. But if you have a pain sensation due to the polyneuropathy, we advise to try some of these painkillers. If it's really complicated, you can also be referred to a pain specialist, and they have more advanced means to help with the pain that you can feel. So if you look at the treatment side effects, I think nowadays daratumumab, bortezomib, cyclophosphamide, and dexamethasone are mostly used in the treatment of newly diagnosed AL amyloidosis patients, and they can have their own side effects, especially in patients with AL amyloidosis. We see more side effects than in patients when we use these drugs in multiple myeloma. So for bortezomib, it's a low blood pressure can be caused by this, neuropathy, neuropathic pain, heart failure, but that's very rare, and increased infection risk. So when you have one of these symptoms, please mention them to your healthcare professional. Dexamethasone can have an effect on fluid retention, but also can increase heart failure symptoms. It can have an effect on how you feel. So patients can experience, I call it ups and downs. So that you feel very energized, that perhaps you talk a little bit much and you're a bit more aggressive in the conversations. But that's the drug talking. It's not you. And also an increased infection risk. And daratumumab is an immune therapy and has not that much side effects. On the short run, it can have some infections, some reaction while injected, but on the longer risk, on the longer time path, mostly increased infection risk. And I did not mention cyclophosphamide or endoxan in this graph, but that's an old-fashioned chemotherapy drug. It can give some nausea, but in the lower dosage that we use, I must say most of the patients experience it. They can tolerate it very well, but nausea can be a problem, and also fatigue can be a problem. So if you have those complaints, also please mention them to your healthcare professional. And because of this increased infection risk with almost all of our drugs, it's very important that you take care of your hygiene. So your washing hygiene, hand hygiene, that you don't go to other people that are sick. To take your vaccinations, how they are prescribed in your country. And in most of these chemotherapy regimens are combined also with prophylactic antibiotics and prophylactic antiviral medication. And I mentioned here, this is the tablets that we use for prevention of herpes zoster. So that can be herpes zoster that can be on your lips. And nowadays we also have a vaccine, and that can also prevent herpes zoster vaccination. In the Netherlands we call it the fever lip, but I don't know the official name in English, I must admit. But if you have infections, or if you want to ask about vaccination, please ask or inform your healthcare professional, because infections can be very troublesome if we treat patients with our treatments for the plasma cells in your bone marrow. Well, I think that was all that I wanted to talk about. And thank you very much for listening. And I will now hand over to Karin for the rest of the presentation.
Thank you so much, Dr. Minnema, for this very comprehensive presentation of the most important things to know about AL amyloidosis symptoms and side effect management. So yes, please, Ms. Aarsman will give a presentation on care coordination, supportive care, and the role of nurse specialists. And I remind everyone that the Q&A feature is there for you to ask your questions, so we can answer them during the Q&A session. So the floor is yours, Ms. Aarsman.
Thank you. Well, first of all, I would like to thank the organization for the invitation. I see it as a great opportunity to talk about my position and role as nurse practitioner in the care for people with amyloidosis, and I'm grateful for the platform I've been given today to raise awareness about this. I have more than 30 years of experience as a nurse, including 15 years as a teacher for nurses. Because I missed patient care as a teacher, I made a switch to the position of nurse practitioner 9 years ago. I decided to pursue a master degree in nursing, and this program provided me in the medical depth and input I needed to understand laboratory results, perform physical examination, prescribe medication, and arrive at a diagnosis through clinical reasoning. And 5 years ago, I joined the hematology team at the University Utrecht as a nurse practitioner. Oh, yeah. Well, this is the program and the topics I like to talk about in the following 15 minutes. The nurse practitioner is a relatively new professional group in the Netherlands. There are since 2000 about 4,000 nurse practitioners working in various fields in hospitals, psychiatric institutions, and increasingly in general practices. The nurse practitioner, also known as the NP, takes over tasks from doctors, namely tasks that are well defined in protocols. Highly complex nursing care and less complex medical care. This makes the healthcare cost more manageable. Because we take over tasks in a defined area, we can specialize effectively. My area of focus includes the care for people with AL amyloidosis, and we are subject to disciplinary law, and the title of NP is legally protected title. And I must demonstrate every 5 years that I have completed sufficient training to continue to practice my profession properly. The nurse practitioner combines nursing treatments with medical treatments. The nursing treatments, for example, focusing on prevention, lifestyle, support and coaching patients with physical or psychological problems and improve self-management. In addition, with my medical glasses on, I perform physical examination, request tests, interpret lab results, and prescribe medication. I also have a lot of contact with other care providers and the family doctor. All of this is done in a close consultation with the hematologist who acts as the primary care provider. Unlike the hematologist, I have 30 minutes for a consultation, which means that there is less time pressure and time to discuss other topics, which I will go into more detail later on in my presentation. After the diagnosis, many of you will recognize the despair in this photo, taken shortly after the diagnosis of this rare disease, whose difficult name causes many people to stumble. It's often preceded by a very uncertain period, during which the search for an explanation for your symptoms has often taken a long time. Once outside the consultation room, many new questions often arise. Because chemotherapy treatment generally starts fairly quickly, you leave the hospital with a whole series of appointments, wondering how you are going to arrange everything. In addition, there may be also concerns about a sick partner. Can you both cope with it all? At home, your children and friends are sometimes waiting for the results, which leads to even more new questions that you don't have the answers to. For many people, it has been a long search, starting with a family doctor and going through various specialists before ending up at the hematologist. After the first consultation, additional tests often have to be carried out, and the results can cause additional stress each time. At these moments, you can use some support. Sometimes you will start with weekly treatment at a day treatment center, which means that your entire week schedule seems to be determined by the hospital. This is also when you come into contact with a nurse practitioner. I will see you alternately with the hematologist during consultation hours, and in preparation for the consultation or afterwards, I will always discuss your situation with the treating hematologist. In addition to Professor Minnema's previous presentation, I would now like to discuss a number of topics that often come up into my consultation room. Fatigue. Some people say fatigue is the most difficult side effect of amyloidosis and its treatment. Sometimes people might look well but still have severe fatigue. And fatigue can make it hard to do everyday things, which can make you feel frustrated, upset, and isolated. If you have continued feelings of sadness, talk to your doctor or nurse practitioner. You may have low mood or depression, and treatment may help. Your family and friends may not fully understand how this special fatigue affects what you are able to do. They may expect you to do the same things you did before, and not realize that some side effects continue for a long time. It's natural for them to want the distress and disruption of the disease to go away. If you find their reactions difficult to handle, explaining how fatigue is affecting you might help them to understand. Knowing more about fatigue may help them understand what you're experiencing. Ways to manage fatigue. Exercise regularly. And before you exercise, it's good to check with your doctor or nurse practitioner what type of exercise is safe for you, especially with the dizziness Dr. Minnema already told you about. See an accredited exercise physiotherapist, and they can develop a suitable program. Start slowly at first and break up exercise into a couple small sessions. As fatigue improves, gradually increase your exercise level and try to be physical active with moderate exercise like walking or swimming, and some strength training with weights or resistance bands. Your sleep routine is also very important. Pace your activities, take regular short breaks, and rest when you need to. Prioritize activities that you enjoy or give you a sense of achievement. Aim for about 7 to 8 hours sleep each night. It keeps the naps short during the day. Sometimes use an alarm so you don't turn it on. Go to bed and get up at the same time every day. And have a bedtime routine that will help. Avoid using computers, mobile phones, or tablets in the evening, and get some natural light during the day to help you sleep at night. And also look after yourself. Eat as well as possible and try relaxation and meditation techniques to help reduce stress. Consider complementary therapies. Studies have found out that yoga, tai chi, qigong can help you with fatigue. But let also your healthcare team know what you are using. They can tell you if it's safe. And involve other people. Tell your family and friends how you are feeling. This can prevent misunderstandings. Accept offers of help, ask family, friends, or neighbors to help you with the household, cooking, or gardening, and talk about how you are feeling with your doctor. They can also assess you if you have a depression. Counseling or medicine, even for a short time, may be helpful. Also, CBT and mindfulness. And connect with a support group, either in person, over the phone, or online. Now I want to switch over to nutrition, another topic I was asked to talk about. When you have amyloidosis, there's a problem with protein accumulation, and a frequently asked question is for people, shouldn't you limit the amount of protein in your diet? I will explain why it's very important that you eat enough protein. And we also want to talk about the importance of protein in muscle building. Cause of malnutrition is the illness. In research, we found out that 65% of the amyloidosis patients are malnourished. Consequence of illness, such as change in taste, difficulty swallowing, reduced appetite, and gastroparesia and intestinal problems are also the cause for malnutrition. Reduced mobility, inability to go shopping or cooking, or if you are sad or depressed, you lose your appetite. And that has consequences. So in your recovery, you lose your muscle mass, and also the immune system is not working well. And it's also a decrease in quality of life, what can lead also to longer hospital stays or higher healthcare costs. So the guidelines says use a high protein diet. Here in UMC Utrecht, we have a dietist specialized, and every new patient she has an intake with, and she will help them to follow the right guidelines. And 1.2, 1.5 grams of protein per kilo of body weight is required during the illness. Protein must be spread across meals, and you must be aiming for 25 grams a meal. Muscle building is also a combination of diet and exercise, and consuming protein before bedtime ensures optimal muscle building. Eat small portions more often throughout the day and don't skip any meals. Choose products with nutritional value as much as possible, and use extra dairy and or savory fillings, and if necessary, supplementary dietary preparation for tube. A dry mouth is also a big problem that can cause problems with eating. So it's important to rinse your mouth often. Use alcohol-free mouthwash, or ask your dentist for lubricants to use. Brush your teeth with a soft toothbrush, and avoid foods that may sting your mouth, such as crunchy or chips or biscuits, or salt and spicy foods. It also helps to soften food by dipping into milk or tea or soup, or moisten it with sauce, gravy. Sip fluids throughout the meal and throughout the day, and avoid smoking and drinking alcohol and coffee as they remove fluids from the body. Then we come to the last subject, sexuality. How does LEL amyloidosis affect sexuality? Most people who have had treatment say the experience changes in sexuality and intimacy. For some, it's temporary, while others need to adapt to long-term changes. Many people find it to be one of the hardest aspects of life after the diagnosis. Sometimes erection problems is one of the first symptoms from AL amyloidosis. And talking about how your sexuality has changed can be difficult. However, the challenges of a diagnosis with AL amyloidosis can also strengthen a relationship, improve how you communicate, and lead to new ways to express sexuality and intimacy. Treatment can directly affect how you have sex, your enjoyment of sex, your desire to have sex, your libido. A serious diagnosis can also influence how you feel about your body, your own body image, your emotions, and relationships. All of these can change how you are feeling about sex. And the stress of a diagnosis and treatment can affect these things too. Any stress you already had in life or in your relationship may become more intense. So finding ways to manage this is important. And will my doctor or nurse practitioner talk to me about sex? Sexuality is a normal and important part of health, but you can't assume your doctor or nurse practitioner will discuss it with you. Unfortunately, that doesn't always happen. The topic may be overlooked for a variety of reasons. Your doctor or MP may think that you don't ask about sex because you don't have any questions. It's something you don't want to talk about. There may not be the time or the privacy needed for the length of the sensitive conversation. Or your doctor or MP may not feel comfortable talking about sex. You may not know that there are treatments available for many sexuality concerns, so you don't think to ask about at your doctor or MP. While some people find sexual intimacy is the last thing on their mind during treatments, others say they have an increased need for closeness. An intimate connection with a partner can make you feel loved and supported as you come to terms with the impact of cancer. However, a disease like amyloidosis can strain relationships, particularly if you had a relationship or intimacy problems before the diagnosis. And unfortunately, there isn't enough time to get into the subject in greater depth, but please see it as an encouragement to make sexuality a topic of conversation in the consultation room. And at the end of my presentation, I would like to thank you for your attention.
Thank you so much, Ms. Aarsman. That was really comprehensive and interesting. I think we have a few questions in the chat, but I would like to start with a kick-off questions. And the question is for both of you. What are your key takeaways from both your presentations and your experience as healthcare professionals? What are your key takeaways to live well with amyloidosis?
Well, for me, my takeaways are that patients with AL amyloidosis can have many symptoms, and many of those symptoms can be worsening during therapy. And also after therapy, many of those symptoms don't go away. So be active in pointing them out, be active in seeking care and guidance for those symptoms. But also there are some things that are here to stay, and adjustment of your life or your your life and how you spend your days is sometimes needed to live well with this disease, because going back to how it was before the diagnosis was made is in AL patients very difficult.
Yeah, it's good. Well, it's all true. Well, my key points are you have to know when you have such a difficult disease and rare disease, you have to know yourself very well. And we also want to work together. So we ask you a lot of things like what's your weight, what's your blood pressure, what are the complaints, and that we really need you to cooperate for a good plan, and don't be shy to ask also the other topics I mentioned just before. Yeah.
Thank you. Thank you. So we have first questions from the audience about diuretics. The question is, the diuretics create severe cramps. How can this be avoided?
That's true. One of the side effects of these type of diuretics is severe cramps, and unfortunately, that's difficult to treat. Sometimes some magnesium intake can help with that, or some quinine, so that's in some drinks like tonic. And sometimes also switching helps. So if you have the cramps with, for example, furosemide, perhaps you can switch to bumetanide, the other type of diuretic, and that can perhaps also help, or switch, or the other way around, of course. So, but it's known it's a side effect of these drugs, and but unfortunately, if you have a very much edema and a swollen body, you can't do without, and then the cramps is hopefully can be diminished, but it cannot be totally gone.
Thank you. And staying on the topic of treatment side effects, are there any other treatments and side effects you would like to share about? I know they're not approved yet for AL amyloidosis, but they are probably already given a lot, or myeloma treatments being given to AL amyloidosis patients. So are there other treatments you want to share about, or is it too early?
Well, I must say, I think with the 4 drugs that I mentioned in my presentation, I mentioned a lot. There's one type of drug that can be used in the treatment of AL amyloidosis that I didn't mention, and they are called immune modifying drugs, or IMiDs, and they are like lenalidomide or Revlimid, and pomalidomide or Omnivid, and perhaps in the old days it was known as thalidomide or Softenon. And these type of drugs are also sometimes used in the treatment. They can have fatigue, infections, anemia, and with lenalidomide it can have a very rare syndrome. People feel extremely fatigued with it. So that's a drug that when you start with it, you have to start on a really lower dose than it's then used in multiple myeloma patients. They can tolerate 25 milligrams a day, but with lenalidomide, the maximum is 50 milligrams a day. With pomalidomide, that's not that much of a problem. So these, and then we have, I think, covered all those type of drugs. Of course, you have different forms. You have, but I think when we really want to move ahead and really want to do much more for our patients with AL amyloidosis, I have a firm belief in immune therapy. So daratumumab is the first immune therapy that we had for multiple myeloma and also for AL patients. But on all the congresses that are presented, we just had ASCO, and we have IHA next week, but you will hear about bispecific antibodies and CAR T cells. And CAR T cells, they have so many side effects. I'm not that sure at the moment we can use them. They must be much safer than we have them at this moment, but perhaps in the future we will. But the bispecific antibodies are much safer and very effective for patients. And the most common side effect of the bispecific antibody targeting BCMA are also infections. So not a lot of other side effects, but infections.
Understood.
But for that, we also are working out countermeasures. So hopefully, we will work that out in the near future.
Thank you. Yeah, thank you. We have a question around managing other diseases. So do you have specific recommendations for patients who may have diabetes or prior cardiovascular diseases or experience with strokes or other cancers, anything that may affect their quality of life and the treatment?
Yeah. So I will give the word to Karin for that, but before that, I want to mention two things because you said diabetes and cardiovascular disease, and that triggered me, and I did not mention it, but some drugs that are used to treat nausea, and that's very common that's common in the disease, but also common with the drugs that we use. They can have a prolongation of your time, that your conduction time in your heart, and we call it QTC time. And especially AL patients are very prone to that. So if you're taking those type of drugs, also please ask your healthcare professional to have an ECG or EKG made to check for this conduction time delay. So that's an important one. And the other one is that I also mentioned dexamethasone. And that's a type of prednisone. And we do know patients with diabetes, when you take prednisone, your glucose level goes up and your diabetes is much more difficult to control with the common use of dexamethasone, especially when it's not stable during the whole week, but we dose it once a week or twice a week. So it's very difficult to have that combination. And also we need your family doctor or other doctors to help us keep stable level for diabetes patients.
Good.
And it's true, and I think, Karin, you mentioned fatigue, that when you had previous treatments already for another cancer, that you already have fatigue when you're
when you're entering. Most people, especially older people, they have comorbidities, so it is a problem to deal with. And that's also very challenging, and that makes it sometimes very harder for people to do the therapy. So we have to tune again all the time. So we see people a lot. At the start, we see them every month, and then we look if they can go on with the treatment, or we have to adjust the medicine.
Yeah. So tuning is a good word. And I sometimes say to patients, I think this is the best treatment for you. For example, newly diagnosed patients, there is hybrid D, but watch out. I think we will tune on the treatment. We will lower one drug or space the cycles a bit more from each other because you need more recuperation time. So tuning, and you hardly any AL patient stays on the regimen that we think of in the beginning. And that's also because we have very strict rules about the hematological response that you need. So you need a deep response. And if you don't see this response halfway, sometimes your doctor will talk to you about changing the regimen or changing some drug in the regimen or adding another drug to the regimen because we want this deep hematological response. So don't expect your treatment to stay the same for 6 months. It normally changes a bit.
Thank you. I guess it's a good way to end the webinar. We have many questions that we haven't answered, and I guess it would be a good opportunity to invite you here again. We have questions around other supportive care and where to seek mental health and what the solutions. Thank you so much for being there today, for sharing your knowledge and experience. It's been a pleasure to have you here. And maybe you want to say, both of you, a final word to the audience before we close the webinar.
Well, I want to thank you again for the opportunity to talk about our work and also the care for people with amyloidosis. And we are very motivated to improve the care for people. Yeah, Christine.
And reach out to Myeloma Patients Europe, because they have great material that can really help you.
Oh, yeah.
Thank you both. And on behalf of Myeloma Patients Europe, we thank you for your participation, and we thank our audience for being there and asking questions. And I wish everyone a nice rest of the day. See you soon.
Goodbye.
Bye-bye.